Wait lang. Okay. So, now, ang i-assess natin dito sa disorders of fibrinolysis is that how well or how unwell is the body capable of dissolving our clots. Okay? In a normal process, ang clots ng ating katawan ay kini-clear out ng ating fibrinolysis system para hindi maging cause ng interference ang clot sa ating normal hemostasis and coagulation. Okay? So now, we have here the initial diseases associated with fibrinolysis. So we have your primary fibrinolysis, or this is also known as your fibrinolysis. So there is a release of excessive amounts of plasminogen activators into the circulation, either from the damaged cells or from malignant cells, such as your prostate cancer. So, class, these plasminogen activators, okay, of this is responsible in converting your plasminogen into plasmin. Now, this plasmin, it has to be bound first and foremost to a clot. So kapag na-activate si plasminogen into plasmin, doon magki-kick in ang ating fibrinolysis. Okay? Now, as fibrinogen is broken down, excuse me. Excuse me. Okay, class. So as I was saying, so as the fibrinogen is broken down, the FSP would accumulate that would be causing an anticoagulant effect that will result in the inability of the blood to clot and thus bleeding occurs. So wag po tayong malilito dito, class. Wag tayong malilito dito sa disorder na ito. Anticoagulant effect. Sir, kakasabi mo lang kanina, fibrinolysis ang pinag-uusapan natin dito. Bakit nagkakaroon ng bleeding? Well, kapag nagkakaroon ng clotting, may nako-consume na coagulation factors. Okay? And kapag natunaw na yung ating fibrin mesh due to fibrinolysis, so pwedeng mag-leak out or pwedeng mag-bleed or pwedeng magkaroon ng inability of the blood to clot sa ating blood circulation. So next, we have your disseminated intravascular coagulation. So I was right kanina that DIC is both a fibrinolytic and coagulative disorder. So, hindi lang naman coagulation factors ang dysregulated or dysfunctional sa DIC. We also have the dysfunction and your dysregulation also of your fibrinolytic proteins or your substances that facilitate or aids with your fibrinolysis mechanisms. So examples of conditions that can result to secondary fibrinolysis or can result to disseminated intravascular coagulation is a systemic infection. There is a presence of snake bites, okay? The venom of the snake bites can cause coagulation and hemolytic transfusion reactions as well. So now, let's now proceed to the coagulation assays itself. So clotting time, this evaluates the clotting factors for secondary hemostasis. We have here the first method, the slide or drop method for the children. We are going to use small amount of blood. So we are really looking for the formation of the fibrin strand. So ang ginagawa dito class, we can place capillary blood to a slide. Okay, ilalagay siya sa slide and we shall be teasing the blood drop. Okay? We are going to be teasing the blood drop for every 30 seconds. Okay? And we're going to check for the formation of a fibrin strand. So, ang ating interval for every 30 seconds, kaya siya tinawag na interval, doon natin i-check or ititease ang ating um, blood drop sa ating slide method. So kapag inangat mo ang iyong instrument, let's say a clean or a sterile applicator stick, kapag inangat mo yung dugo at may lumitaw na manipis na strand, that is your fibrin. And we will stop the time. We will stop the time kapag nagkaroon tayo ng formation of a fibrin strand. Okay? So you have your capillary tube method, or this is also known as your Dale and Laidlaw's method. On this method, we are using the capillary tube with the blue mark, so that contains no anticoagulant. Yung red marked na capillary tube natin, that contains heparin. Okay? So that is prone to skin puncture. Okay, let us do skin puncture and place the blood into the tube and break every 30 seconds and check for the formation of the fibrin strand. So napakadaming ah, container ang kailangan nating i-collect sa itong capillary tube method na ito. Okay? So we have your Lee and White blood coagulation time. This is insensitive to factor deficiencies. Why? Because again, this is just a qualitative reporting on your coagulation as on your coagulation time. So hindi niya kayang mag-differentiate ng iba't ibang uri ng coagulation deficiencies. Now you have your activated clotting time. So this is used for patients that are undergoing heparin therapy. So this uses an activator. You have your diatomaceous earth, which contains 12 milligrams of diatomite that stimulates the clotting factors. So I want you guys to take note of the following laboratory evaluations of intrinsic and common pathways. Again, you have your intrinsic factors, you have your factors 12, 11, 9, 8, and the contact factors like your high molecular weight kininogen and your prekallikrein. So your common factors include the factors 5, 10. You have your 2 and your 1 and your factor 13. So please take note of the third bullet right here. So the problems of intrinsic and common pathways are related to diseases. Liver diseases. Okay? So with this realization, can we use prothrombin time PT test? Can we use PT test if we can differentiate liver diseases associated coagulopathies from nutritional disorders like your vitamin K deficiency? Can we use factor 7 to differentiate liver diseases from your vitamin K deficient coagulation factors? Ano sa tingin nyo, class? Can we use factor 7 to differentiate vitamin K deficiency from liver diseases associated coagulopathies? The answer is no. Why? Because generally speaking, all of the coagulation factors are synthesized in the liver. Okay? I repeat, all of the coagulation factors are produced in the liver. But if we are to consider which among here, which among the coagulation proteins are best to identify liver disease associated coagulopathies, then that would be your factor 5. Your factor 5. Factor 5 deficiency is more associated with liver associated coagulopathies. Coagulopathies. Okay? So other conditions that we might encounter is the presence of circulating anticoagulants like your heparin. You also have your hypofibrogeninemia and your lupus inhibitors. So your lupus inhibitors or your lupus anticoagulants. This is usually encountered in patients diagnosed with systemic lupus erythematosus. Then your hypofibrogeninemia, since your fibrinogen is a part of your common pathway. So this can prolong both PT and PTT tests. So what are the tests that we can use, okay, to assess the intrinsic and common pathways aside from the PT-PTT? So you have your clotting time, your activated clotting time. We also have your plasma recalcification test in which we are going to add 0.025 moles of your calcium chloride. This is your recalcifying agent. So the specimen that we shall be using is your citrated platelet poor plasma. Again, I repeat, the specimen that we shall be using is citrated platelet poor plasma instead of the whole blood. Okay? Because red blood cells tend to prolong the clotting time. Okay? So your platelet-rich plasma can also be used. Okay. This can also be used to screen for platelet function defects. So we have here the reference ranges. So you have your activated partial thromboplastin time. Okay. So just to give you some extra information regarding the PTT test. So the thromboplastin component is composed of lipoprotein and phospholipids. So this is used to screen for deficiencies in the intrinsic and common pathways that is used to monitor or to check for heparin therapy. So it measures all factors with exceptions to factor 7 and to factor 13, because again factor 7 is more associated with PT test extrinsic pathway. Okay. So the reagents that we are using, the phospholipids are obtained from the rabbits. Okay. Most especially from the rabbit brain or plants. Okay. And activators such as your choline, salite, silica, and your ellagic acid. So we are going to start the time for your APTT upon the addition of your calcium chloride reagent. So you have here the reference range of 20 to 45 Celsius, in which APTT results lesser than 20 is significant of thrombotic tendencies, while values for greater than 45 seconds, 45 seconds, okay, is more associated with hemorrhagic conditions. So you have your extrinsic pathway, okay, your factor 7 and your factor 3. Factor 3 is technically your calcium that is affected by vitamin K deficiencies and your anticoagulants, warfarin, and coumadin as well. So we have here your first test, your prothrombin time. Saan siya ginagamit, class? This is useful for the monitoring of oral anticoagulant therapy. So as mentioned earlier, this is used to detect deficiencies of vitamin K dependent group except for factors 9. Because again, factor 9 is a part of the intrinsic coagulation pathway. Intrinsic coagulation pathway. Now, the reference range for your prothrombin time test is 10 to 12 seconds. So, madali lang pong gawin ang PT test. Okay? So, the specimen that is required for this, for prothrombin time test is your citrated platelet poor plasma. Platelet poor plasma. We have here your International Sensitivity Index, which is according to the World Health Organization. The standard is 1 when buying the PT reagent. We have here your international normalized ratio. So this is used to standardize the reporting of the prothrombin time. It generally minimizes the difference in prothrombin time results. Okay? So this is used to monitor patients that are currently taking up anticoagulant therapy, and please take note of the um, normal ratios of the international normalized ratio for normal persons and for persons taking oral anticoagulants. So you have here your Vence time or your Russell Viper's Venom test. So let's just run through with this. We have your Venom obtained from your Verepa Rosselli. So what is the purpose of your Vence test or your Russell Viper Venom test? The venom is capable of bypassing the action of your factor 7. Okay? Factor 7. So, ang activation kasi class ng ating extrinsic factor usually begins with the conversion of your factor 7. So, instead of inducing the extrinsic factor, okay? Instead of inducing the extrinsic factor of factor 7, lalaktawan niya ang factor 7 activation. So that will directly convert the factor 10 to your activated factor 10. So this is used to check problems or deficiencies for factor 7 and factor 10. So, please take note, itong importanteng dalawang results na ito. If you have a prolonged PT, eto nga po, prolonged prothrombin time and prolonged stipends time. You have a deficiency for factor X. Okay, you have a deficiency for factor X. Okay? Now, if you have a prolonged PT and a normal stipends test or stipends time, you have a factor 7 deficiency. Now, for your fibrinolysis from your fibrinogen assays, you have your thrombin time in which it will be prolonged if the fibrinogen is below 75 to 100 milligrams and perhaps there is an impaired fibrinogen function. So this is affected by circulating anticoagulants and this is sensitive for heparin inhibition. Okay? So you have your reptilase time. So reptilase time, this is unaffected by heparin or your circulating anticoagulants. So reptilase is an enzyme that is found in the venom of your Botrops atrox. Okay. And please take note of the reference of 10 to 15 seconds. So you have your factor 13 assay. We have discussed this earlier, your Duckert's assay or your 5 moles urea solubility test that is used to check for stability of clots. So, ano ba ang ginagawa natin sa 5 mole urea solubility test? So, the plasma is mixed with thrombin. So, that thrombin essentially activates your factor 13 or your fibrin stabilizing clot. Okay, so the function of your urea is it would try to dissolve your um, factor 13. Okay, it will dissolve your factor 13. Okay, so the deficiency or rather the deficiency of your factor 13, it can easily dissolve the clot. Okay, the reagent can easily dissolve the clot because again your factor 13 is the one that is stabilizing your fibrin monomers. Your factor 13 rather stabilizes your fibrin polymers. Kapag kakaunti ang ating factor 13, unstable ang ating fibrin polymers. Madali siyang tunawin ng ating Dockert's reagent. So you also have your other coagulation studies. You have your thrombin clotting time. Okay. So the addition of thrombin bypasses all coagulation reactions except the polymerization of the fibrinogen. Kasi class ang thrombin automatically ang specificity niyan is it directly converts fibrinogen into fibrin. So, hindi na natin dadaanan yung mga other coagulation proteins. Okay? So, this is prolonged by heparin. So, this means that this can also be used to monitor heparin therapy. So, any range greater than 8 to 9 seconds can be associated to a heparin overdose. So you have your Fletcher factor assay. So the specimen is a citrated platelet poor plasma. So the reagent that is used for your Fletcher factor assay is the reagents for your APTT and your calcium chloride. So a deficiency and the Fletcher factor will also prolong the APTT. Okay. Excuse me, class. Wait lang po. Ay, oh my God, I'm sorry. Buti na lang na-point out mo. Naka-mute pala ako 'no?
Opo sir, hindi late ko po nasabi kasi hindi po namin napansin na lumilipat na po yung slide. Naka-mute po sir. Mula ata po nung nag-start ka after the short break po.
Okay. So, ang haba pala. Sorry, sorry.
Sorry din po, late po namin nasabi. Hindi po kasi namin sure eh.
Saan ba ako nag-short break? Dito 'no? Class pasensya na medyo sinusumpong kasi ako ng ano, ng acid reflux ko. Shucks. So, anyway, I'll try to push through. Saan tayo na hinto? Test for inhibitors 'no? Okay, sige ulitin ko na lang class 'no? Or actually ano, dito sa area na ito, you just really need to understand that we are looking for the presence of inhibitors. So, kapag may fibrin clot na nade-develop, so ibig sabihin, hindi na inhibit ang clotting process. So, kapag wala tayong clot na na-develop, then merong presence ng inhibitor. Okay? Class, pasensya na. May ano lang. Pasensya na class. Bawi ako bukas. So you have your tissue thromboplastin inhibition test. So the specimen that is being tested is the citrated um, platelet poor plasma. So you have here your diluted thromboplastin, your calcium chloride, and your control sample. So ito po yung proseso na nangyayari. So you have your citrated platelet poor plasma. Then we add your diluted thromboplastin reagent and your calcium chloride. So that is incubated at 37 degrees Celsius. And then the clotting time is measured. So the results are expressed in ratio. So the normal is 1:1, the borderline is 1:2, and your abnormal is your 1:3. So now, we shall be dealing with the laboratory analysis of your primary hemostasis. So pag primary hemostasis, we are now going to see the function of your platelets. Okay? So this can be a test to assess the platelet adhesion and also your platelet aggregation. So it all starts with identifying the characteristic of the platelets that we want to assess. So let's start with the quantifiable traits, the number of the platelets. You have your thrombocytopenia, and you also have your thrombocytosis. So thrombocytopenia, that pertains to a decreased number of platelets, and your thrombocytosis, this is a increase rather in platelets. So we have your direct method, your indirect method, and your automated method. So your method, this involves the suction of your EDTA test tube to your Sally Hillage pipette, while your indirect method usually involves the direct observation on your peripheral blood smear. Okay? And you also have your automated method, your hematology analyzer. So you have here your direct method. So under your direct method, you have your Brecker, Cronkite, your Tocantins or your Riesenecker, your Guy and Leaks, Nigards, Walker, and Sweeney's reagents or methods. So you have your Brecker, Cronkite method. Ano po ang ginagawa natin dito? So I just want you to memorize this area. So Brecker, Cronkite method, this is regarded as the reference method for the direct platelet count uh, computation. So we use a phase contrast microscope and we use a diluting fluid of 1% ammonium oxalate. So this lyses the red blood cells and allows the platelets to form pseudopods. So mas madaling magbilang ng platelets kapag enhance ang kanilang pseudopods. You have your Tocantins method, or also known as your Riesenecker's method. So we can use your hemocytometers and your Thoma pipettes as well. So on this, we are using a simple light microscope. So the diluting fluid that we are going to be using is the Riesenecker. So the contents would include neutral formalin, sodium citrate, and your brilliant cresyl blue. Okay, so with this, we can visualize the presence of platelets under the microscope. So we are going to be counting, okay, 25 red blood cell squares. Okay. So if the counts are low, we may use a WBC pipette with 1 is to 20 dilution factor for the Rees and Ecker. So for this one, you have your indirect method. So with this, we can use this to estimate the number of the platelets to allow the visualization of the platelets morphology. We also have here Fonos method and Dameshek's method. So per every 100 red blood cells, that pertains to 3 to 10 um, platelets. You have your automated method, optical to electrical charge, or rather electrical methods, in which there is the involvement of the degree of light scattering. So that pertains to the optical, and your electrical charge or change in the electrical resistance or capacitance across a circuit. So ano ibig sabihin nitong automatic method na ito? Class, kapag nagkakaroon tayo ng clot, okay, nagkakaroon tayo ng increase in, or rather, um, a decrease, bumababa po ang ating light scattering. Okay? As the clot develops, there is a decrease in light scattering because the light that is being transmitted is being blocked by the developing clot. So yun ang ating mechanism sa automated method. Kapag nagkakaroon ng clot, nagkakaroon ng turbidity, na-diminish ang light scattering at humihinto ang oras dahil doon sa development ng ating clot. And that is observed in your optical methods or automated optical methods. So, for your qualitative platelet test, qualitative, so we are looking for the activity of the platelets. We have here the first test, the capillary resistance test or the tourniquet test or the Rumpel leads test. So this can be used by applying a pressure cuff onto the forearm. We are going to inflate the cuff of the sphygmomanometer at 100 millimeter per mercury, okay, for 5 minutes. So we are going to count the petechiae after 15 to 30 minutes. So ano ba ang petechiae? This is the bruising on the forearm due to the ruptured capillaries. Pumuputok po ang capillaries natin kapag tayo ay mababa ang ating platelet count. So as you can see, right here, we have here your grades 1 to 4. So habang tumataas ang grading, mas tumataas ang number ng petechiae. Okay? So you have here your platelet adhesion test. Ano ang minimeasure natin sa platelet adhesion test? The ability of the platelet to connect to non-platelet surfaces. So we have here your platelet retention test or your glass bead retention test that uses EDTA or heparin blood sample. The blood is passed through a tube containing beads, then the platelet would adhere to the beads. Okay, so we have here the first tube, the second tube, and the third tube. Okay, so we have here your platelet adhesiveness test or the Salzman's test. Okay, we have here the in vivo. So, ibig sabihin, sa loob ng katawan, tinetest ang ating platelet adhesion test. So, you have your bleeding time. This is the time required for the skin to stop bleeding. So, bleeding time is essentially determining, okay, how well the platelets can respond to plugging up the wound. Kasi dito sa bleeding time na ito, sinusugatan natin ang ating patient or ang ating client. So, what are the types of the bleeding time? We have here the Duke's test, kung saan earlobes ang sinusugatan for infants and children. So, the normal value is 2 to 8 minutes. So, anything greater than 8, that can be suggestive of a platelet adhesion problem. Okay? You have your modified IVs test. This is hindi na siya talaga masyadong ginagawa sa clinical practice. Okay? Kung meron mang gumagawa ng clinical practice na bleeding time test, that is perhaps ordered by an old physician. So talagang hindi na updated ang kanilang mga knowledge. Yun na yung nakasanayan nila. Okay? So you have your modified IVs test. So cut is going to be inflicted 5 centimeters below the antecubital fossa. Okay? And the pressure cuff is also applied to this area, to the antecubital fossa, at 40 to 60 millimeter per mercury. Okay? Our next test to assess the platelet adhesion test is the clot retraction. So the serum is expressed from the clot and then the clot becomes denser. So ang ina-assess naman natin dito is the function of your thrombostenin. So it will assess the entire platelet function and the coagulation test. So when can we identify abnormal clot retraction test? Thrombocytopenia, mababa ang platelet count, mababa or abnormal ang fibrinogens, presence of paraproteinemias, and Glanzmann's thrombasthenia. So other methods, you have your Hirschsprung method, okay, that would use castor oil and we would look for the formation of the dimpling phenomena. And we also have your McFarland method that is check after 1 hour. We are going to check for uh, clot formation by using a wire loop. Okay, so this involves some computations. You have your Stefanini's method or Stefanini-Dashemek method. Okay, so the clot retraction is checked in this series of hours: 1 hour, 2 hours, 16 hours, 18 hours, and 24 hours. Tinitignan kung gaano kahusay ang ability ng platelets natin in coordination with the clotting factors to form a solid clot. So we have here your platelet factor assays. You have your platelet phospholipids that provide surface to which clotting factor will it bind. So it would need patients platelet poor plasma and platelet rich plasma. Then, kukunin natin yung clotting time ng dalawang plasma na ito. Okay? Then, you have your platelet factor 4 and beta thromboglobulin assays. So, the specimens must be refrigerated prior to testing. So, this is used as an indicator. I want you to have this takeaway. Platelet factor 4 is used as an indicator for platelet activation and myocardial infarction. This is for diabetes and venous thrombosis that can also be measured using radial immunoassay as well. And lastly, we have here the platelet aggregation test that uses an aggregometer that follows the principle of photoelectrical detection. So the specimen would include citrated platelet-rich plasma. So specimens to consider, um, the patients must fast at least 8 hours to avoid lipemic specimens because lipemia will tend to affect the accuracy of the test. So it must not be placed in refrigerator because it will cause platelet aggregation. Okay. Then the specimen must not be hemolyzed to avoid the release of the ADP, and no aspirin within 7 days because aspirin is known to affect the platelet aggregation of our samples. Okay. So I guess that ends the discussion for the laboratory assessment of our primary and secondary hemostasis. Okay.